we are going to select a lucky winner of our Excellence Insight Analysis, which will be conducted by CO. The intent behind that analysis is to help identify members with a propensity for certain types of surgery and then work with your vendor or vendors to help drive them towards centers of excellence to get the best outcome possible. It's a study valued at $25,000, so be sure and check to see if you're the winner, and congratulations in advance to whoever that lucky person is. What I'd like to do at this point is introduce today's speakers. Cindy Ewert is a seasoned human resource and benefits professional who's been involved in the management and administration of benefits and HR shared services since 1997. Cindy joined Energy Future Holdings in October of 2009 and is currently responsible for the strategic planning and administration of compensation, benefits, payroll, and HR shared services for Energy Future Holdings and its subsidiary employees and retirees, of which there's about 30,000 lives, including dependents. Prior to working for Energy Future Holdings, Cindy worked for Centex Homes as the Vice President of Benefits and HR Services until such time as they were acquired by Pulte Homes and moved their headquarters to Detroit, Michigan. We're also going to be joined by Den Bishop. Den serves as the President of Holmes, Murphy & Associates, as a shareholder, member of the Executive Committee, and National Practice Leader. Den is responsible for employee benefits corporate strategy. He's respected throughout the industry and is an inaugural member of both the Aetna and United Healthcare National Broker Advisory Council. Den also serves as chairman of the board of ACAP Health. ACAP stands for the Accountable Care and Accountable Patients, reflecting the company's revolutionary way of delivering measurable results and lower healthcare costs. We also have Renee Stolmeyer, who's worked in benefits and compensation at Genesis Health System for nearly 14 years. Renee received her bachelor's degree from St. Ambrose University and is pursuing her MBA at Western Illinois University. In addition, Renee is PHR certified. I am Craig Abrahamson. I am going to be filling the host roles for David Hom, who unfortunately was unable to join us. I am the Director of Employer Solutions at CO Health Analytics. I've got a little over 20 years experience in the national accounts healthcare industry, working at a few of the major players. My role here within CO is to lead our Employer Services and Solutions group, working with employers from a solutioning and strategic planning perspective and internally to help operationalize all of the needs of our employers. And so with that, I'm going to turn this over at this point to Den Bishop. Den?
Thank you, Craig.
You're welcome.
As we start off the discussion today, I wanted to kind of make a few points and kind of set the stage a little bit. We're often hearing questions, and it's more from CEOs, I think, than from within the benefits and HR sides of customers, but it is the question of why are we still doing any of this? With healthcare reform, aren't we just going to be able to get out of the way in terms of our role in healthcare? And if you look at what's going on in the space and what's going on in healthcare, there are a few key items. I'm trying to get to next slide here. Craig, there we go. With that, if you look at roles that are going on in the healthcare system right now, on the federal government side, that 1114, I think in some ways people looked at that a little bit like Y2K, that once that starts, are we over and done with, and does it all go into a new world? And very much like Y2K, I think we'll wake up the next morning and the world will look exactly like it did the day before. Major healthcare programs are the primary driver of all of our future deficit and debt discussions in this country. Healthcare programs are about to become the largest single expenditure by the federal government, and it is by far the largest driver and variable in our future debt and deficit. Because of that, the influence of the federal government in healthcare will never go away, and it's only going to increase over time. With that, there's a second assumption or a second key point that's there, and that is the system will be primarily funded with employer dollars. And the reason that I say that is if you go back to the Congressional Budget Office scoring of the original healthcare reform legislation and every update that they've done since that time. If you look at the most recent update of the forecast for the cost of healthcare reform, and you look out 10 years for how they see the world working and how people will be buying their health insurance, 10 years from now, the Congressional Budget Office actually is projecting that more Americans will be receiving their health insurance through their employer than do so today. You look at some of the surveys of large employers saying 10 years from now they believe that they're going to be out of health insurance. But the federal government, in essence, can't afford that to happen at a cost at that time of between $7,000 and $8,000 per person in an exchange who's receiving a subsidy. The more employers get out and exit the system, the federal debt and deficit seems to skyrocket that's there. So the federal government really can't let the employer out, and I think you will see legislation over time continuing to utilize employer dollars and put mandates in terms of what it will cost employers to get out or make sure they stay in the system. And my final point that's there is that even with the changes that we're seeing in legislation, the employer group is still the primary insurance rating pool. So even if someone decides that they're going to look at a private exchange, do something down those paths, the cost of insurance for your employees is still based on the risk and claims experience for your specific employer group. So if you take those three fundamental statements or assumptions, it puts employers right back in the middle of healthcare the way that they've been for the past decades. And even though there's a lot of change going on, the primary financing and who's going to be responsible for paying for it is not changing. And that leads us to a second item that I would like to point to, if I can get the slide to change one more time here. Thank you. Oh, there we go. With that, employers really have two choices, and I believe only two choices. Many employers believe that they can kind of stay in the middle in what they're doing today, and I think that's a very risky place for a business to be. On one side of the case is an employer who says, I'm out. And what I'm out doesn't mean that that employer no longer offers health insurance to their employees. What it means by I'm out is that my business can no longer or is no longer willing to take on the inflation risk of healthcare. I'm going to give people money. I'm going to find an administrative platform, and wherever the cost of those programs goes, it goes. But I am out from a risk standpoint, very much like a 401k. If you think back to 2008 when the stock market tumbled, employers at that point didn't respond to that and say, you know, next year we're going to have to dramatically increase our 401k contribution because all of our participants lost significant value in the market last year. That's not how employers responded. In fact, most employers responded by decreasing or eliminating contributions the following year because of the difficult business climate. That same mindset really needs to evolve for the employer that says they're out in healthcare, that it's no longer our issue. We're giving you dollars. What happens, happens, even though the primary risk pool is still at the employer level. On the other side of that chasm, and I think it's where most employers are, is that they feel that they still have to offer a program to their employees that's very competitive within their marketplace. And with that, they're in essence still in the game, sharing risk with their employees and trying to find a way to increase the value, perceived and real, of their healthcare program. And those employers, instead of shifting financial responsibility, I believe will be increasing health responsibility. That can take several different looks. It could be aggressive wellness programs. It could be strong clinical compliance programs. It could be very narrow networks. But the employers that still retain risk, I think, will move even more aggressively of trying to positively influence the risk inside of their population. To do that, they have to have measurements. They have to know where they're aiming to know whether they hit that target or not. And I think that sets the foundation for today's discussion. First up, from the employer standpoint, Craig introduced Cindy Ewert with Energy Future Holdings. And Cindy, I will let you take it away, and I will chime in when I deem appropriate.
Okay, and it looks like, well, maybe if I can control the screen. Okay. Thank you, Dan, and welcome everyone. Let me give you just a little background on Energy Future Holdings. We are a utility company that consists of a regulated and non-regulated arm. Regulated meaning we're regulated by the Public Utilities Commission, and because of that, there are certain things that part of the business can and cannot do, which adds restraints to some of the things that we do from a benefits perspective. And then the non-regulated obviously is in the open market and subject to all the market pressures as everyone else. Our demographics in one part of the business is literally 90% male that are probably between 48 and 49 average age and seek very little, if any, health care. And because of that, when they have an event, it's typically catastrophic, which is the first thing that got my attention. The rest of the business, if you look at us and average that in, we look fairly normal. We're 50% male with an average age, of 39 to 40. One of the things that first got our attention, which, like to Den's point, having analytics helps you know where you need to first target your efforts, is that in that part of the business where it's 90% male, we saw that 75% of that part of the company had not received any care, any health care, not preventative, not otherwise, for at least 3 years, which was pretty astounding. So that was why we started with that area of the business. Additionally, working in our favor, being a utility company, we have very long tenured employees, and so the fact that they're long tenured and we probably have less than 5% turnover in that organization means that whatever efforts we take, we'll actually reap the benefits of, because we don't have high turnover. So hopefully whatever we put in place will actually reap the rewards of that. So our first thing was to figure out what the barriers were to care, why were they not seeking care, and what could we do to remove them. So we decided and explored with the population its access to care. They're mostly in rural areas of Texas, with care being few and far between. There's cost, and then because they live in a rural area, their families also are far away from care. So the first thing that we did was, let's see if the, can't change the slide. Oh, thank you. So we wanted to increase primary care usage. That was actually our primary goal, is to get everyone to get screened, get physicals, and at least identify if they have risk factors or gaps in care and start working on those. Our largest area of expense happens to be musculoskeletal. I think both from an age standpoint and the fact that it's a very manual labor job, musculoskeletal was a primary focus. So we first deployed a MobileDoc, a very novel idea where we literally built a rotating clinic that drives from site to site, where we have about 1,000 employees in close proximity, relatively close proximity to each other. And it spends a week at each site, and both the employees and the dependents can seek care there. It's run by a nurse practitioner, and they can go there for their primary care or urgent care if they have an issue while they're at work. Again, we targeted musculoskeletal first, and we worked with another company called Arasti to do more preventative musculoskeletal work versus surgical work, and see if we could help people get better without surgery. Thank you. So we took the MobileDoc to the East Texas population, and I'll show you numbers here in a minute about how much participation we've had. But we partnered with a local provider system called Good Shepherd, and in doing so, when they encounter things that cannot be handled at the mobile clinic, they are easily in close proximity to refer them to their centers of excellence. Because we had so much success with the mobile clinic, we opened a on-site clinic at our call center facility. Much to our chagrin, we found out that the call center employees were probably in worse shape than our guys in the field. But again, very high participation, very well received by the employees, and have made great inroads in catching things early and or undetected things that people were unaware of, and then starting treatments on those. We're now looking at opening sites in Central Texas and another on-site facility in East Texas.
Cindy, I may kind of one item on the timing of that connection back to Good Shepherd, in that, if I recall correctly, initially you did not have the mobile clinic connected with an organized system of care. That was kind of a second generation item when you started seeing referral patterns. Is that correct? It
was. We first worked with a company out of Dallas that was not connected to any near-site providers, and it pretty much failed miserably. I mean, it worked for the people who were being seen at the clinic, but it did not work as you needed to take further action and close gaps in care. So we, like you said, second generation, we got connected to a provider group out there, and that has been a wonderful evolution. On this slide, these are the steps that we took this year to further incentivize those that have not engaged. For example, everyone doesn't have access to a clinic, and obviously our office personnel are not involved in the mobile clinic. So we further wanted to get and capture the groups that had not gotten engaged. So this year we put in plans that are called My Health Plans, that in the past we would have funded their HSA and HRA with the employer contributions at the beginning of the year, but now they do not get any funding until they've actually completed the required preventative steps. And so for each preventative step that they complete, then they get the funding for that. We had a overwhelming rush to get care on just before and after open enrollment this year. We priced our My Health plans much cheaper than our traditional plans, and then the funding is greater than what they could get today, and the employees reacted very positively. And we probably have, between the two My Health plans, roughly 70% of the population is now in the two new My Health plans. And like I said, a rush to go get preventative screenings that they probably didn't even, it was not on their radar. Our colonoscopy, just for example, obviously everybody doesn't need one, but for those that did, we went from like a 10% rate to a 35% rate just in the last quarter of 2013. Our physicals jumped from about a 25% rate to a 65% rate or 70% rate. So people are now getting those preventative screenings that we want them to, so they're certainly reacting to the incentives in the way that we want them to.
Cindy, with that positive move and things like a colonoscopy screening, how much of that, given the workforce. It's a blue-collar workforce that you're trying to incent to make that move. How much of that do you think was a financial incentive? How much of that do you think was the messaging that was there?
In all honesty, our people react to money. And I'll say that because we've given the wellness message for quite some time. And some people have responded to that, but by and large, the response has been to the incentives. They definitely, we got their attention with the way we price the plans and the incentives they're available for. So even though people know it's the right thing to do, there was not enough incentive or push to get them to actually take the action. So, let me try. These are some statistics from both the mobile clinic and the TXU clinic. The mobile clinic has been open since about September of 11. And the TXU clinic just opened in February of 13. Okay. Some of the additional slides, which I am not going to talk to you too much, but when you look at our high-risk population, particularly in Luminant, which is the rural community, we had 49% of our employees in a high-risk category with 4 or more risk factors, according to the metabolic syndrome statistics. But after just a year, we saw that shift. We still have people that have a lot of risk factors, but you see that shift moving from 4, 5, and 6 down to 1, 2, and 3. And so we actually are very excited to see the numbers start moving in the right direction. So it shows and tells us that by people going for their screenings and things and actually taking action, that we're seeing those risk factors reduce over time. So back to Den's comment, you know, obviously we have taken a we're in approach versus we're out, and our intent is to continue to influence and reduce risk so that we can control our costs. Some of the, so if you look at deaths from preventable diseases, and you see a significant drop from 11 to 12, like I said in the beginning, that's why we have a slide on life claims. I've never worked at a place where literally every month I have 1 or 2 deaths come across my desk, and preventable deaths. So it was very concerning, and which is what was spurred us to action to go figure out what was stopping them from getting care, so that when they had an event, hopefully they'd survive the event and not end up as one of these statistics. These are some of the services that are available through the MobileDoc. These are the same services that are available at all the clinics. We focus mostly on preventative and primary care, but again, they will treat urgent care as needed. And there's a picture of the MobileDoc. It's literally a semi that drives from site to site.
So
and I think we're holding questions to the end, but if there's something that we need to address right now, I'm happy to do that.
Thank you, Cindy. We'll come back. As we transition now and look a little bit at Genesis Health System, a very different employer situation in that it wasn't a population that didn't have access to care. In fact, they were the provider of care as a health system. But nonetheless, what you will see, as we hear from Renee, is another employer facing a completely different set of issues and how they have proactively taken the information available to them, created measurable targets, and then moved to try to influence those specific risks. So Renee, you want to take it from here?
Sure. Thanks, Dan. Yes, we are a health system. We are very large. We expand over several cities and many miles. We have over 5,000 employees. We're the third largest employer in the Quad City area. But unlike Cindy, our primary population is female, and average age is about 45. So back, if you want to go to the next slide, please. We back in 2008, we'd actually read in a Holmes-Murphy brochure about a program that they were offering and they were having success with, and we were able to convince our CEO to give it a shot, and it was metabolic syndrome and going after a wellness program. So we started with our leader pilot. We had 125 of those leaders participate. Then in 2009, we opened it to the employees only, and at this point, our wellness program was testing for metabolic syndrome, and we were offering a Naturally Slim program, and we were rewarding you. You were earning a discount as long as you were going through the program. In 2010, we invited spouses, or actually required spouses if they were on the insurance, to go through the program as well. And then in 2011, we added tobacco screening to this, and then we also that we give a discount if you pass the wellness screening, and we doubled that discount. And then in 2012, we moved to results, which meant instead of just giving you compliance for going through the steps, we actually asked for some results-driven, and I'll talk about those in a little bit. So, and then this year, our big thing is we've actually increased our discount even further. So the next slide, please. This basically is just a timeline of the same, and it talks about how much our discount is. And again, it was basically $400 or $800 off of their wellness screening back in 2010, and this year we're up to $2,000. And that would be for an employee and a spouse, so it's half of that if it's just an employee on the plan. And so what we do is they go through a metabolic screening, and we do this in November during our open enrollment, and they have an opportunity to rescreen in May. And if they And it's an all or nothing. At this point, we have tobacco as part of it. They have to have either, if they have 5 risk factors for metabolic syndrome, reduce it to 4, and we require tobacco-free at all. There can't be any tobacco usage at all. So we have, basically what we have found through this is, again, money speaks volumes, and we have a success in our compliance because we have a pretty hefty differential that you earn if you can pass the screening. So the next slide. This is talking about the percentage of our participation, which we feel is very, very high. We had 82% of our employees that take our insurance participate and earn the wellness discount. And in 2011, you see it drop to 70%. But again, this is when we added the tobacco component, and that's a difficult thing because it's both you and your spouse. And we had a lot of employees whose spouses simply don't want to give up tobacco, and therefore they just sacrificed earning the discount. Our goal in all of this is to have a healthy population. And we are a healthcare provider, and we strive very much to be the model for healthcare, and we feel that this is an okay thing, and we are lucky that our community supports it. The competition also has a smoking component or a tobacco usage component to their wellness program, so it definitely helps us, and our community is trying to go smoke-free, so it helps us and it supports us, and we still feel that 70% earning a wellness discount is pretty great. So the next slide. This is our CEO's absolute favorite slide. He shows this a lot. It is the trend of healthcare costs and then what Genesis has been able to do. And we have, for all intended purposes, been able to keep our costs flat. We're still pretty much where we were back in 2008, costing what we cost in 2012. And we owe this to our wellness program. It's pretty self-explanatory. The red line is where the trend is for their costs, and we are still down around $8,000 for total cost. So we're pretty proud of this slide. And I think it tells a good story. And the next slide talks about the savings.
Renee, let me,
go ahead,
sorry
Jed.
about that.
Yep.
Can we go back
You
to the
can add
previous
to
slide? I'll kind of comment on previous slide. I think one of the things, seeing what we have seen across all types of employers in different parts of the country over this time, it sometimes gets lost in this slide because the savings for the employer are so significant compared to what national norms have been over that time. But if you look at the orange box, the orange box is the deductible, copay, coinsurance, how much of the dollar had to be paid by the plan participants over this period. And in 2007, the average cost was $1,409 for the employee portion of this. In 2012, it was $1,390. In other words, the plan design value between 2007 and 2012 actually increased just slightly in the Genesis population. And I think by dramatically moving the needle and risk inside of the population, not only have you held employer costs at a rate that's much lower than the increase of the rest of the country, but you've also, in a time where most employers have pretty significantly reduced benefit values for their employees, have been able to keep the value of the plan whole, if not better, in the fullness of your entire program. And from an employee satisfaction standpoint, not being in your walls every day, I have to assume that annual chip away that most employers have to endure in their relationship with their employees, you've been able to avoid a big piece of that.
Yes, thank you for pointing that out. That is true. We have not shifted our costs to our employees in order to save money. It's been a collaborative effort, and our program has been successful, and therefore our employees are feeling the same savings that we are. And the next slide speaks to the difference that we've made and how much money that Genesis has actually saved over the years through this savings. And we say that the total savings over 6 years is $64.2 million. So we're very proud of that. The next slide just talks about the summary of the screenings. And again, it's talking back at the 2008 when we started it, and the percent that screened and the percent that had met us. And what's really critical to see in this is not just the fact that we've screened a lot of people, but our percentage of met us is going down. And again, our goal in all of this is to have a healthy population. And these numbers, it's not necessarily the same people. We do have turnover. So we are creating a healthier environment. We are employing healthy employees, and it's lasting and it's contagious throughout the organization, and people want to be involved in it.
Renee, I may comment on that slide too, as I keep interrupting for color commentary on things, but I get so excited about seeing what you've been able to accomplish. One of the pieces that we often hear is the ability to influence spouses and the challenge that represents. And at Genesis, there was such a commitment from the leadership to really go at and also try to positively influence that. Part of it was from a cost standpoint, because if we look in most populations, you will see spouses on a per unit cost end up being 40 to 60% higher than the employee cost. It is very normal that's there. And I think another very significant thing that Genesis was able to accomplish was moving that spouse population from 2009 at 34% of that population having 3, 4, or 5 of the metabolic syndrome risk measures down to 18% in only 3 years, I think is an amazing result that also has a significant impact on your cost about improving that risk for spouses, which I know many employers are hesitant to do, but much gets back to the employer belief around whether it really is your role to have that influence or not.
Yep. I appreciate
any comments at all, Renee, about when you started reaching out and including spouses in that, positive or negative, around how your population responded to that?
It's interesting. There's always you're going to have mixed information, but I will tell you now we have employees thanking us for driving their spouses to get healthy. I think a lot of them wanted to have a reason for their spouses to get healthy, and dollars to save on their insurance was a reason enough for their employees to get healthy. And if you look at the difference between 2011 and 2012, and when we dropped from 26% down to 18%, that's when we changed to results. And so they had to do something to earn the discount. And now we have spouses thanking us. So it's been good. The next slide, this just talks about basically the sustainability of what we have done. And if you look, the end's only 27, but this is because this is from our pilot, and these are only the people that had met us at the beginning. So that number of 125 of those employees that first screened that had metabolic syndrome and that are still with us today. So that's why back in 2007 it was 100%. It's down to 37%, and so this is the same population who these 27 people have reduced their risks and kept it off. And here we are back 2012 screening, and I think that that's really successful, and it's pretty powerful to talk about, because that's one of the biggest challenges we had when we were making this pitch was, well, that's great, there's results. How do we know it's going to have long-term effect? And this slide proves that it does have the long-term effects. And I think the next slide basically talks about the same thing. It's still, but this is going from all metabolic syndromes, or all metabolic syndrome participants from 2007 today. So this is anybody that's had the metabolic syndrome, and again, every year we have people that keep it off and reduce. So we've had a 58% reduction in metabolic syndrome over those years. And the risk factor reduction, the next slide, again, this shows how with this movement from the 5 risks down to the 4 risks to the 3 risks, and it just talks about the reduction. And in every category, we've had success in reducing risk factors for our population. And these are the 5 we test every November for these 5 factors that make up the metabolic syndrome. So the risk factor change is the next slide, and it just is, again, it's more support of our reduction and how we've been able to move people from 5 risk factors, in some all the way down to 0 over the years. And our next slide is the risk migration, and it's a scatter plot. Kind of isn't fitting fully on my screen. Hopefully it looks different on yours, but it basically is just, we want to move people up and to the left. They're the people that cost us the least, and the people that are costing us the most are down and to the right. And we've been able to shift those employees and all the participants, employees and spouses, and move them to a healthier area. So the next. Okay, thank you. Again, it's more support for the longevity of this, and how back in 2008 we had the combined area, the 15%, the 8%, and the 3%. Those were the people that had the metabolic syndrome, and how we've been able to take that over the years and reduce that down to the 15%. So it's other people, it's new people, again, that are in there, but again, we're able to keep those people that once had metabolic syndrome out of having metabolic syndrome, and the new people that we have added to it, we are hiring and creating an environment that supports healthy workers. So we're overall, our population is healthier.
And I think in any industry, Renee, these are impressive results for where your population is right now based on this data. But to have a population and a workforce where 67% of the population has 0 or 1 risk factors is phenomenal.
I think that you basically say that the general population is 25% with metabolic syndrome, and we don't. So we're proud of that. And the last slide that I have is the other favorite slide of ours, and that goes back to the tobacco risk reversal when we added that. The year after we tested, the first year that we required they stop it's the next slide, please. We were able to have a 34% reduction in tobacco use, and when we rescreened of those 116 people that tested positive, the 96 that rescreened, 70 had remained tobacco-free. So that is long-term still keeping people off of tobacco use. And we just went through our screening for 2013 or for our 2014 benefits in November, so we're anxious to see if we're able to even keep more people off of the tobacco use. Those are all the slides I had. Den, is there anything else you'd like to add? I went through them kind of quick.
Well, I've got questions, so I'll start in for both of you. And I think my first question is how you were able to gain executive approval to make the types of investments in two very different areas based on the unique cultures and needs of both of your populations and your companies. But both Energy Future Holdings and Genesis Health System have made significant investments in order to, in one case, close that gap in primary care and access to care and in referrals to high-quality providers, in the other around risk factors and metabolic syndrome. But how did you gain the executive approval?
Cindy, do you want to answer?
Yeah, this is Cindy. I'll go first. I mean, part of it is just what is your alternative? You know, if you go back to Renee's slide, when you look at the trend, we have similar slides too. I mean, the option is let that trend continue on that track. Well, no one can afford that. And if we want to continue to provide health care and a benefit to our employees, then we have to do something. And while the numbers may not have been exact, the alternative was certainly not something that the company could sustain. So a little bit of it is just on faith and that doing the right thing and getting people engaged was going to produce the right results.
Yep, and Genesis was similar. We had a situation where we knew that we needed to do something. We needed to make a change, and we are a community-owned healthcare system, and we are the healthcare system, and we wanted to be the role models. We wanted to be what we try to make our community. So we chose the wellness program versus other options that we looked into as cost savings through our benefit plans. And the Holmes-Murphy pilot or program that they had done had some success, so we were given a year. We were given a year to give it a shot, see how it went, and immediately felt it was the right move for us. So we have every year challenged, how can we make it better? How can we make it better? And even, I mean, I know that I'm going to go starting in January, and our CEO is going to say, great, that was great. How are we going to make it better? So.
And knowing your CEO, yes, that is what will happen. On other end of the spectrum on getting support and approval, obviously both companies have used financial incentives to try to move the population, as I sometimes refer to as the George Washington readiness to change model. If we put enough dollars out there, very often employees may be ready to change when they otherwise might not think that they were. But how did, inside of both cultures, one with a union population that you have to try to move in some things, the other with nurses that very often competition for hiring nurses is very tight, sensitive populations in two different ways, how were you able to get the buy-in and support other than just the money of here's this and go?
Well, we started with our leaders. And our leaders went through the program first, and when I mean leaders, I mean executives as well. And they immediately, it's really powerful when you see people that you kind of look up to and lead the organization say such wonderful things about the program and believe it so wholeheartedly, it's almost contagious. So it's never been challenged in a way that we're forcing employees. We were never forcing employees. They don't have to go through the program. They don't, it's still their option. And then we just really focus on our communications. We live our mission, and our mission is to have a healthy community. We're part of that community. So it's almost, it's everywhere. Our cafeteria, we have no fry Wednesdays. It's just we encourage, we have mile loops around our campus where we encourage people to get out and go for walks. So it's not frowned upon to be healthy. It's really, really encouraged.
And we're not dissimilar. We don't have quite as much leadership engagement as I would like. However, with the clinics, even our leaders go to the clinics and use the clinics and set the example. The CEO of TXU, who we just put the on-site there in Irving, was one of the first ones to go through and get his physical, as well as his whole senior staff, so that people were comfortable using the clinic. We also have, maintained the carrot versus the stick approach to date, in that it's voluntary and that it's for their benefit, and we have emphasized that in all of our communications. So, people are, while we're incenting them, it's for their benefit and their choice to participate or not participate.
So another question, if you could go back in time and go back and redo or change something that you've done or not done in terms of trying to attack specific measures that you found or other items in terms of influencing your risk, what things, if you could rewind the clock, would you maybe do a little differently that the audience could learn from?
Renee, I'll let you go first.
Okay. Honestly, I don't know if we really would have. I really feel, and in fact, if I were to coach an organization, I would tell them to do it the way we did it, and we did it in baby steps. And each year, we added a component or changed it slightly, making it a little bit, when we switched from adding in the spouses, and then the next year when we added in the tobacco, and then we moved to results versus just compliance. Each of those steps was strategic in the fact that we were doing it for the right reason, and we felt that the employees and their spouses were comfortable with what we had done. And so when we kicked it up a notch, it wasn't earth-shattering, and yet it was still acceptable. Mm-hmm. So I think it worked well, and I think if we would have put too many changes on them all at once, we would have gotten resistance. If we would have charged too much at one time, it would have gotten, the discount would have, if that would have been too much at one time, we would have gotten resistance. So I'm not sure I would have changed anything. That's probably not the answer you want, but it's just, it really has worked very well for us.
I think if most employers had your financial results, they would say the same thing.
Right.
Yes.
And while I would love to have sometimes moved faster, I think we've done the same thing in that we have taken it a step at a time and moved a step at a time, which has allowed and promoted the engagement that we want to happen. And I think that we would have had the same results as Renee if we had tried to do too much too soon. And if you have to pay attention to the culture and the willingness for change. And if we had moved, just personally, I could have jumped from 0 to 100, but knowing the culture, we took it, from 0 to 10. Mm-hmm. And worked our way up, and it seems to have had a much better positive effect. And again, gotten tremendous engagement. So I don't know that I would change anything either. I did, having never and no examples to call upon for building the MobileDoc, I learned a whole lot of things about mechanics and running a moving clinic that I didn't want to know, but now I know I should have asked in the first place.
You could run a bus company now.
Yes, yes. Yeah.
So a similar thing, and kind of want to hit this with both of you and get your opinions, because somewhere there's a magic combination of program and curriculum combined with culture. And both of you, with very different corporate cultures, have both found a way to move those cultures in a positive direction. How do you balance out in evaluating opportunities that specific curriculum versus culture item? And that may be a terrible question, but I think there's something fascinating within both of these case studies of how using very different approaches, you've both had fantastic results.
I'm not sure I understand the question.
So let me rephrase it a different way, and I'll actually push it to Renee on this one. So we saw in that initial group that was there, you've got now a 6 or 7 year sustainability of a reduction in the risks associated with cardiovascular disease and diabetes that's there. I am not a believer that there's any magic curriculum that can all of a sudden make America healthier that way. We all kind of basically know that we should probably eat a little less and move a little more. But where do you think that having the right curriculum or program is, and how much of that sustainability do you think is a culture change where it was actually the cool thing to do to be healthy? How much would you credit on each side of that equation?
If I am understanding your question, I think that it's a truly mixed bag. We offer multiple programs that we support for employees to try to improve their lifestyle. We offer the tobacco cessation programs at no cost to them. We have stress reduction programs. We offer a lot and allow them to decide what's most successful to them. We, within HR, we might have our preference that we believe is a little bit more successful than others, but at the same time, at the end of the day, that's why we move to results, because as long as you can do it and as long as you can improve your lifestyle and become a healthier overall, then we're happy with that. The culture is really, it's very effective that, and we're fortunate that we are a hospital, or we have a cafeteria and areas that we can choose what we put in our vending machines, and we can choose what we sell in the cafeteria, and we give our employees big mugs to have their water in. So I think that our culture is probably more effective than the program that they would go through, but I think that we've got great programs too.
Yep.
So.
Yep. All right. My last question for today, and we'll wrap with this one, and this one is probably primarily directed towards Cindy, but Renee, you may have some thoughts on this too. Cindy, having some insight into places you would like to go in the future and some of the things that you're exploring, are there any insights that you would share with other employers regarding challenges or opportunities in working with your insurance administrator on integrating or supporting programs, and kind of what your experience has been in that, positively or negatively, and what guidance you might give to somebody?
Well, I don't know that we have figured out the answers, but I would say that my advice and my charge, if you will, to the people that we work with, i.e. the Blue Crosses or the other administrators out there, is that we're all, those employers that are choosing to stay in are trying all kinds of things to get that engagement and change those risk factors and start moving things in the right direction for our organizations, and that it's going to take a new paradigm shift with the administrators to be able to support that, whether that's through analytics, you know, and reporting, or the way we administer claims, all kinds of things. Because, you know, I mean, today I have a challenge with a lot of activity happening outside of the claims system, you know, in the clinics. In some way, I have to be able to take that data and integrate it with my other data to be able to look at any point in time, my total population health and where I still need to focus and make change. And today that's very disjointed. And so the advice is, you know, push and try to get all the partners that you work with on the same page, and, you know, thinking differently and working differently to make sure that the employers get the information that they need to be able to make decisions. Yeah.
Fantastic. I think we are at the close of our time. Craig, any closing comments from your perspective?
Yes, I would first like to say thank you again to Cindy, you, Den, and Renee for sharing all of your information and your insights and your experience. I'd like to thank everybody who was able to attend the webinar. And a couple of reminders. One, that we will be sending out a link to a recorded version of the webinar sometime in the next few days. And a last reminder that we will notify the winner of the CO Analytics Center of Excellence Insight Analysis a little later this afternoon. And just again a reminder as to what that analysis is. It's a study that brings together tools, technology, and a pool of specialized experts with knowledge of all your key business challenges. The analysis will provide insight into your data, including recommendations to help you improve your business key performance indicators. And with that, I will say have a great afternoon. Thank you again, everybody, and a happy holiday season.
Thank you.